let's move on then and talk about the approval of the second generation able TKIs in the newly diagnosed CML chronic phase patient. And there have been four trials, but three major trials that have led to the approval: an SND for nilotinib, decision for dasatinib, and the before trial following the BELLA trial for bosutinib. And I'm going to start with an SND. And that was a trial in CML chronic phase patients, about 280 patients in each arm, who were randomized between imatinib 400, you could argue about that as the baseline, or 2 doses of nilotinib, 300 twice daily, or the then approved dose in the resistant and intolerant setting, 400 twice daily. The primary endpoint of the study was major molecular response at 12 months. And it was statistically significant, 44% with nilotinib, 22% with imatinib. The other thing, we now, however, have 5 years of update and 5 years of follow-up, and that study continues in follow-up for 10 years. And what have we learned? We've learned that the rates of progression are lower with nilotinib than imatinib, especially again in the first year. We've learned that there's no statistically significant difference in survival, but if you look at CML-related deaths, there was clearly a decrease in the number of CML-related deaths that was not offset completely by other non-CML-related deaths, including cardiovascular deaths. We also found that with the second-generation drug nilotinib at 300 twice daily, by 5 years, 54% of patients had an MR 4.5 compared to 33% with imatinib. So deeper responses at 5 years, but even in terms of my initial goal of therapy is to prevent progression, I think we do that by achieving a higher rate of MMR and also a higher rate of CCYR at 1 year, 80% versus 65% nilotinib to imatinib. You also achieved higher rates of 3-month response. 91% with nilotinib achieved a BCR-ABL ratio less than 10%, and it was 67% with imatinib. So all of these efficacy endpoints favored nilotinib, and in terms of discontinuations, they were similar due to adverse events, but there were actually fewer discontinuations on the nilotinib arm than imatinib because of a combination of efficacy and toxicity. So in terms of preventing progression, that's important. Now we have 5-year data saying if we're going to start thinking about treatment-free remissions, a little over half of the patients, around half of the patients, got to that and that 4.5, and it at least might be candidates for treatment-free remission. Let's move on to the data for dasatinib in the decision trial.
So pretty similarly, a pretty good number of patients, over 500, randomized between imatinib and dasatinib. Same questions, looking at major molecular remission, 5 years of follow-up. I think we have the similar conclusions. With 5 years data, there's clearly more major molecular remissions, more deeper molecular remissions. There is some protection against progression. There was a little bit of the race for cytogenetic response was equalized a little bit sooner in the decision trial. I think what's most important is those advantages when you look at the other important issues, which is being able to stay on drug, having adverse events, progression, overall survival. Similarly, the survival is similar across the study. The new side effects that came through in decision were not surprising. Pleural effusions were noted as a new primary toxicity with dasatinib, although fortunately those aren't limiting in most patients. I think it again shows the value of starting with a second generation TKI with a good safety profile with a specific side effect or a specific adverse event you need to look out for, and the ability to do all the, kind of to hit all the buttons to achieve a deeper and faster molecular response, to have some protection against progression. Again, maybe not as clear as some of the other data, but and I'm intrigued by the fact that dasatinib, like the other TKIs, we continue to look at the dose, and I think there's recently published studies looking at even lower doses of dasatinib, which could even offer a better risk-benefit ratio. So the story continues.
Yeah. And before I move on to bosutinib, I did forget a very important toxicity, long-term toxicity that came out in the STEND trial, and that's cardiovascular events. I believe the second-generation drugs in general have higher risk of cardiovascular events, and whether that's because imatinib is protective or second-generation drugs have a higher risk, I'm not certain. But in any case, it was about 9% of these events occurred on the nilotinib arm and 3% on the imatinib. Bosutinib and the BEFORE trial you just presented at the ASCO meeting.
Yeah, so we just presented at ASCO in 2018 the 24-month follow-up. And you mentioned there were 4 studies because there's 2 studies that have been done with bosutinib. I'll briefly mention them because I think there's some value there. The earlier study, which was the BELLA trial, randomized, same design as you had mentioned for the other studies, bosutinib versus imatinib. And in that study, the dose of bosutinib was 500 milligrams, which is the standard dose for salvage setting, second-line setting. That study, the primary endpoint was complete cytogenetic response at 12 months, which was not met. Everything else was met. Major molecular response, transformation rate, all these other secondary efficacy endpoints were met, but not the primary endpoint. Part of the problem was the treatment discontinuations early on. So the subsequent study, the BEFORE study, which is the recent one and the one that led to the approval, had 2 major changes. One was the dose of bosutinib, 400 milligrams daily, and the other one was the primary endpoint, major molecular response at 12 months. And that was met. That was presented ASCO 2017. The drug was approved in December 2017, and we presented a 12-month follow-up. So this is an earlier study, so we only have 24 months, but the differences remain, as you would expect, 61 versus 51% rate of major molecular response. There is a trend for fewer transformations in the bosutinib arm as well. So I think that it follows the same trend, and that the fact that there is a benefit in terms of earlier responses, deeper responses with the second generation. The toxicity profile with bosutinib, the things to keep in mind, diarrhea is very common, but usually mild. Most patients have just grade 1, grade 2. 80% of patients are going to have diarrhea, but it's usually grade 1, grade 2. It is extraordinarily rare that you have to discontinue therapy because of diarrhea. It's very highly manageable, although most patients don't even need management like intervention, medical intervention. The other toxicity to keep an eye is liver toxicity. There's some elevation of transaminases, usually manageable with adjusting doses and that kind of thing. Few patients, again, have to discontinue therapy because of liver toxicity. There seems to be a bit less cardiovascular toxicity with bosutinib. The follow-up in this study is short. With the BELLA, there was about an equal incidence compared to imatinib. We'll have to follow this study further.